Continuing education credits, including ABP maintenance of certification for physicians and other healthcare professionals, are provided by the Penn Medicine Continuing Medical and Interprofessional Education. Check out our website at www.thecribsiders.com for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Sam Mazer, unfortunately not Chris the Chu Manchu, but I am joined tonight with my co-host and super producer, Sydney Engel. Say hi, Sydney.
Hello.
All right, and our guest tonight is Dr. Lisa Spector to discuss speech and language delays. But first, Sydney, can you remind us about the show?
Of course I can. We are the Pediatric Medicine Podcast. We interview leading experts in the field to bring clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine. Tonight, we have a fantastic conversation with our guest, Dr. Lisa Spector. Dr. Spector is certified by the American Board of Pediatrics in Developmental and Behavioral Pediatrics and General Pediatrics. She's Division Chief of Developmental and Behavioral Pediatrics at Nemours Children's Hospital in Orlando and is a professor of pediatrics through the University of Central Florida. She co-leads the Central Florida Behavioral Health Hub and is the co-chair of the Florida State Health Improvement Plan Mental Wellbeing and Substance Abuse Prevention Priority Area Work Group. She's a board member of the Mental Health Association of Central Florida. She teaches us about developmental milestones, hearing testing, and what families can do to support language development.
All right, let's talk about something that doesn't always speak for itself.
Nice.
Let's talk about talking. Hi, Dr. Spector. Thanks so much for coming on the show. First, because we're an informal group, I'd like to ask, is it okay if we could use your first name?
Absolutely.
All right. So, Lisa, we're hoping that our audience can get to know you a little bit. Can you give us a one-liner to describe yourself? Maybe something interesting in medicine and something outside.
I'm a developmental behavioral pediatrician who came to this field after a career doing child abuse pediatrics. I'm also recently divorced and embracing the single life.
Now, I have to ask, how did you find yourself in developmental and behavioral pediatrics from child abuse pediatrics?
Yeah, child abuse pediatrics was very rewarding. Also challenging, right? You're seeing children and families at one of the most stressful times in their lives. And I started to realize that in order to be proactive and preventative, developmental behavioral pediatrics was the ideal choice, particularly the behavioral part, which is one of the things that I love the most about it. So how do we instruct parents on behavior management strategies to impact positively children's behaviors, thus reducing their need to use things like corporal punishment?
Oh, I see. I can see the connection now. That's amazing. And did you have any strong mentors or someone who was had used to done that field, or anyone who had changed or kind of paved this way of that transition ahead of you? Or was this just something that came out of your time in child abuse pediatrics?
Yeah, it was quite honestly the time of counseling. As a pediatrician, we're counseling families about kids who come in with injuries and talking to them about not using corporal punishment. And they would say, well, what should I do instead? And I'm like, I don't know. I'm out. And they would say, I did time out, it didn't work. And I'm like, well, try it again. And so then when I got to Kansas City and they had a robust developmental behavioral peds program there, I was like, oh my gosh, this is gold. Why do we not learn this stuff as pediatricians? I need to know this stuff and to help disseminate the knowledge. So
I absolutely love that. And I feel like that makes you the perfect guest for this podcast, because that is exactly the sort of thing that we're trying to do. So thank you so much for being here. I was wondering if you could just share one good piece of advice that you've gotten during the course of your career.
Yeah, it pertains to behavior management. So one of the most important things that I learned is that behavior change doesn't happen overnight. It really takes baby steps. So we have to be patient. We might have to tell our patients and families the same thing 10 times, 20 times. It's like planting seeds. Sometimes those seeds will be planted, it'll be nourished, and they'll grow and they'll blossom. And sometimes those seeds go unwatered, and we just have to keep planting more seeds every time they come in.
A perfect springtime metaphor. I love it.
All right, so let's actually get to the case. Sometimes we ask 3 questions, but we actually have a whole bunch of cases today, and hopefully we'll make it through all of them. Sydney, would you mind starting with the first one from Cashlight Children's? One of the things I've always appreciated about medicine is that you're never really done learning. Whether you're a medical student on your first rotation, a resident finding your footing, or years into practice like Chris and me, every day is another opportunity to learn something new. And if you're spending that much time in the hospital, having scrubs that are comfortable, durable, and actually look good makes a real difference. That's one of the reasons I've been a fan of FIGS for years. And so, Cribsiders listeners, it's here, back to school season. And while that means lectures, labs, and late nights for healthcare workers in training, it's also a reminder that in medicine, education never really ends. And right now, FIGS, the premium apparel brand for healthcare professionals, just dropped fresh colors and exclusive back-to-school styles. And the best part? Everything is 20% off site-wide for a limited time. From scrubs to outerwear to footwear and beyond, FIGS keeps awesome humans looking sharp, performing their best, and ready to take on anything, from marathon lab sessions to 12-hour shifts. So if you're in healthcare or know someone who is, don't miss out on 20% off for back to school happening now through August 11th at wearfigs.com. That's wearfigs.com.
Definitely. Okay, so first case, Ethan is a 9-month-old boy, 8 months corrected age, who was brought to Cashlack Children's primary care by his parents for a well-child visit. He was born at 36 weeks gestation with no significant perinatal complications. His parents report that Ethan is meeting most of his developmental milestones. He sits without support, he transfers objects between hands, and he reaches for toys. However, they're concerned because he isn't yet making sounds like ma 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 or ba 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 ba, and he doesn't really seem to respond consistently when they call his name. On examination, Ethan appears well-nourished and interactive. He makes good eye contact and smiles responsively. His gross and fine motor skills are appropriate for his corrected age. However, during the visit, Ethan is notably quiet and doesn't vocalize or babble spontaneously. When you observe his response to sound, Ethan does not consistently turn towards the voice or environmental sounds. So to start us off, can you just give us an overview of the patterns and the big milestones of normal speech development during infancy?
Absolutely. And a great reference for people is the CDC developmental milestones, whether it's for pediatricians or for families, and it was recently revised. But we'll talk about it in broad scopes, like so birth to 3 months of age. There's receptive language, what we take in, and there's expressive language, what we put out. So in terms of receptive language, it's startling to loud sounds and being quiet when they're being spoken to. They also start to make those cooing sounds, often vowel sounds, and they responsively smile at people, or they'll spontaneously smile at people, particularly around 3 months of age. So the 4 to 6 months of age, they start to turn their head towards sounds or respond to tones of voice. They also start to blow those cute little raspberries where they get the bubbles at their lips, which is basically when they're sticking out of their tongue and they're blowing. And then they start to look at themselves in the mirror and enjoy doing so. Then 6 to 9 months, they start to recognize the names of familiar people. Like if you say, "Where's daddy?" or "Where's mommy?" they'll turn to look towards that person. They start to string those sounds together, as in this case of mama, 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 or da, 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 or ba, ba, ba. And then they start to use gestures, like put their arms up in the air to be picked up, or pointing or waving. And then by 9 to 12 months of age, they understand no. So if you say no, they have a response to that. They start to specifically call mama or dada, or a different special name. And by the way, dada often comes before mama because D is easier to say than M. I'm sure you guys already know this. And they start to wave goodbye as well.
And for those milestones, when we talk about these, we're generally talking about the 50th percentile. Is that correct? So some kids a little bit above, some kids a little bit below, or is this like the bottom percentile, the 3rd percentile? This is the minimum that we expect them to do.
Yeah, I mean, this is the range, right? Exactly. So all development is a range, right? So it's at certain windows of development that we see these developmental progress. And there's certain time points where if we're not meeting certain milestones, then that's when we start to get more concerned and alerted to something going on. But this is generally thought of as a range, right?
And so we'll kind of start, we're going to talk about speech delay if people haven't already guessed that. And so let's start very basic with what are risk factors for some language delay?
Yeah, so there's multiple factors that can impact speech and language delay, from prematurity, so born before 37 weeks gestational age, as is your child in the case, as well as low birth weight, so under 5.5 pounds. There's also a pretty significant genetic component to speech and language delay. So if there's a family history of a parent or a sibling having language delay, it improves increases the likelihood that a child may have the same thing going on for them. There's a vast number of genetic conditions that have some association with speech and language delay for various reasons. You can have congenital or acquired hearing loss that can be related to perinatal infections, genetic causes, or chronic otitis media for the acquired hearing loss. There can be neurological issues going on, so cerebral palsy or brain injury, whether it's at birth or soon after birth. It can be oral motor issues like cleft palate or muscle weaknesses. And it can be also related to the environment, particularly lack of language exposure, if there's abuse or neglect, or there's excessive passive screen time usage can impact speech and language development as well.
So I imagine we're going to jump into all of those things during the course of this conversation, but I would love if you can help us delineate in what cases you might be more concerned for there being an underlying pathology or primary cause of language delay, whether we are talking about one of those genetic conditions or a hearing disability. And maybe this question is too broad because there are just too many underlying possible diagnoses, but I'm wondering if there are any sort of red flags that would make you want to do a more thorough evaluation during infancy.
Great question. Particularly, think about this case, for example, this child is really having a hard time responding to sounds, whether they're extraneous sounds in the environment or people calling the child's name. So I would for sure be concerned about hearing loss. So any child that has language delay, we would need to make sure they're getting their hearing tested to determine there's something else going on, and doing that as early as possible because the time is precious. I'm trying to make sure that I'm answering your question as thoroughly as possible. I think there's lots of different. So in terms of, thinking about some of the other big diagnoses, particularly things like autism, right? So while autism doesn't inherently have language delay, because of the deficit or difficulties with social engagement, which is a core component of autism, and because language and social skill development are intimately intertwined, language oftentimes is impacted with kids with autism. So if somebody is struggling with their social skills, gesture usage, responsive social smile, that's another good reason, in addition to screening them, as we are recommended to do, right, with our MChats.
I think we should probably start talking about the hearing piece a little bit. And you were talking about how evaluation early is so important. Let's just talk about the timing, right? We talked about the CDC milestones are ranges. And so at what point, so we're talking about a 9-month-old right now, but at what point on the edge of that range do you say, I think there might be a problem and we should start with evaluation? For example, if they're supposed to do it from 6 to 9 months, do you wait till 9 months and 1 day, or are you really waiting till 12 months? What is your practice when it comes to getting ready to do that evaluation?
Yeah, so if somebody's 15 months of age and they have fewer than 5 words and no interest in communicating with other people, that's a huge red flag and a reason to send them off to be evaluated. If they're 18 months and they have fewer than 10 words and no imitation of words or sounds and no use of gestures, that's another good reason to refer. If they're 24 months of age and they're fewer than 50 words or they're not putting words together, which is a common developmental milestone for 2, right? 2 years, 2 words together, another reason to refer. And if they're 36 months and their speech is mostly unintelligible, so by 36 months or 3 years, we should understand 75% of what they say. They should be putting 3 words together. And they should be able to follow simple directions if they have a hard time following directions. And they're not participating in a back and forth vocal interchange with people. That's another reason to be concerned. The biggest reason to be concerned, though, is if they have any regression of language. So at any point in their development, they're going backwards. That's not good.
Awesome. So you just mentioned some timing that's starting at 15 months, for example, and then going upward. We're taking this kid at 9 months. Are you really not going to do anything? And sorry, I don't mean to put you on the spot to say not do anything, but are you not as concerned about doing something immediately when they're really less than 15 months? Or is there something that you want to see differently at, say, 9 or 12?
Yeah. So at this point in time for this child, I would definitely be doing something. So I would strongly encourage this child getting a hearing evaluation because the child right? We're talking about receptive versus expressive language, right? So he doesn't seem to be recognizing or receiving some of the language or the sounds around him. So that's making me concerned that he has a hearing, something's going on with his hearing, perhaps. And then, so he's 9 months, 8 months corrected age, and he's not making sounds. So if he's not able to hear, it might impact his ability to imitate and thus make the sounds. If he is able to hear, then I would better, ask more questions. Is he making any vowel sounds? Has he just not gotten to making the consonant vowel sounds as of yet? Maybe he's making vowel sounds and he's starting to emerging to use those consonant sounds, which is great and good. If by the time he got to be 12 months of age and he's still not vocalizing at all whatsoever, that's a huge red flag.
I really love your way of delineating by age all of these different kind of red flag milestones. I feel like in a general pediatric setting, that's a really helpful framework for thinking about when to take the next step. I have a follow-up question about the hearing evaluation, which is what about in those cases that are kind of the opposite of this case, or maybe a counterpoint to this case where you have patients with very good receptive language skills, but they're not producing expressive language. It's obviously an older infant, not a 9-month-old, but they're following one-step directions. When the mom says, give me this object, they know what object they're saying. Would you still refer for audiology, or would you give it a little bit more time in those cases?
It's generally recommended that children who have any kind of language delay at a young age always have a hearing test. So I would still recommend them get a hearing test because we don't know the amount of sounds that they're able to hear, right? They might be hearing something, but maybe not the full range of the decibels of sound that they should be hearing, which might be impacting their language usage or expressive language too.
Awesome. And then how does that change based on age, for example? Like when they're newborns, they have specific tests where essentially they just put a probe in the ear to see what's going on versus when they're older toddlers, they can follow instructions. Where does this kind of land when you have later in infancy? What do the hearing tests look like?
So everybody's going to have a newborn hearing screen, right? And if they pass that, great. If they don't, then they have more invasive-ish tests completed to assess their hearing. And then as they get older, they have more interactive hearing tests that they engage in, where they have sounds emanating from different sides, and then they have to let the examiner know where they're hearing those sounds from. They do a lot of so many different components in terms of assessing one's hearing, right? So looking in their ears, assessing the sounds that they're able to hear, as well as the fluctuation of the tympanic membrane.
Perfect. So it sounds like they can do a hearing test at all ages. Sounds like it can start whenever you notice any speech delay. So it sounds like our recommendations, you have speech delay. We kind of talked about the age range that you'd be concerned about. We talked about the milestones that we want to make sure that we hit. And if we don't hit those, we're referring for hearing testing, as receptive language could be a big issue. And so the whole thing is completed. Let's say for Ethan that the hearing screen is negative. What would you recommend being the next steps? Is this a referral to early intervention? Is this a speech evaluation? What do you kind of do next as a developmental pediatric provider?
Yeah, early steps is, early intervention, and it's called different things in different states, right? So in Florida, we call it early steps, but as a birth through 3 program is absolutely essential to make sure they're referring children and families to the early intervention in their state or their region, their county, because it provides free services for them. In some states, they might, instead of getting a speech and language pathologist coming to their house, they might get an early interventionist. So sometimes there's a bit of a dilution of the therapy. So I think it's important for primary care providers to know that when they refer to early intervention, they might not be getting a speech and language pathologist coming to the home. So in addition to referring to early intervention, I always refer to private therapies as well, just in case. So I would refer to both, quite honestly, in this situation and all situations of language delay for all children.
That's a great tip. And then can you speak a little bit more about what you would recommend to the family to support language development at home?
Yeah, this is the most important part, quite honestly. Well, one of the most important parts. So It's really important for parents and caregivers to use language as much as possible. And sometimes it feels uncomfortable at first. We talk about like just narrating your daily activities. And for some parents, they're like, what? That feels so uncomfortable. But once you start doing it, it really becomes very easy. And you just start naturally doing it on a regular basis. And as we all talk about, especially with projects or programs like Reach Out and Read, and that program is so vitally important, really integrating books back into the family life. Books are an integral part of a child's development. Not only do they help build one's language, but they also help to build that connection, that emotional relational health between the child and the caregiver. And it helps the child build attention, to be able to sustain attention, to look at something with the caregiver. And it's a great way to expose children to lots and lots of language. So books. And then, making sure that we're responding to communication. So when babies are vocalizing, it's so important for us to vocalize back. Like just reflect back what the sounds that they're making, or start talking to them or saying things or singing to them, whatever. That back and forth interchange of they say something, we say something. It's the foundations for building more complex language as well as social skills as well. And then along those lines, I would say really limiting screens. It's kind of really so hard, I get it this day and age, but it's so vitally important to really limit specifically passive screen time. That means that the child's watching something without somebody accompanying them and talking about what they're seeing. And then play. I cannot emphasize enough playing together, like quality play time with kids. So it's a great opportunity for us to give them labeled praises, for us to describe with our words what they're doing, and us to reflect back what they're saying. So those are the key things I would say.
Awesome. So just kind of summarize our case here. So it sounds like for Ethan, we're starting to get some delayed language, whether that be receptive and then also expressive that comes with it. But we're trying to see that. We're saying, hey, we're not meeting our milestone right off the bat. We'd recommend hearing screens. Hearing screens, if they are past the hearing screen and still notice this, we're referring to speech and language pathology, both for the early intervention program and whether it be a private speech and language pathologist, just to make sure that we actually get speech development. And then at home, this is the key. Talk, read, play, no screens, over and over and over and over again. And as awkward as it sounds, you can't have too much language in front of your child. That's kind of what I gathered from the first piece. Does that sound like a good summary?
Absolutely. I would say, but instead of hearing screen, it's literally hearing testing. Like it's audiological testing,
Yeah.
Yeah. So you want to make sure you're doing audiological testing, because a screen is a different level. We've identified that they've kind of like failed our clinical screen in terms of talking to them, right? Not an official screen that they had in the PCP office, but they need the testing.
Right,
yeah.
Right. We are actually screening developmentally, and then testing for hearing is actually what we're doing. We're not screening for hearing and the other way around. Okay, perfect. One thing I've become increasingly aware of as a physician, and especially as someone who's also pretty visible online through the Cribsiders, is just how much your personal information is out there on the internet. Your address, phone number, family information, a lot of this stuff is surprisingly easy to find. And if you've ever had anyone really cross a boundary, you know why that can be concerning. That's why doctors, lawyers, executives, journalists, and even podcasters are using Delete Me, because we know what's at stake. Your personal information is already out there more than you probably realize, and it can put your safety at risk, especially as attacks become increasingly sophisticated thanks to AI. That's why I use and partner with Delete Me. They remove your info from hundreds of data broker sites so you don't have to track it down yourself. One thing I really like about Delete Me is that it isn't just a one-time service. They're constantly monitoring and removing the personal information you don't want on the internet. And they do all the hard work of wiping you and your family's personal information from data broker websites. So Cribsiders listeners, stay smart out there, take control of your data, and keep your private life private by signing up for Delete Me, now at a special discount for our listeners. Get 20% off your Delete Me plan when you go to joindeleteme.com/Cribsiders and use promo code Cribsiders at checkout. The only way to get 20% off is to go to joindeleteme.com/Cribsiders and enter code Cribsiders at checkout. That's joindeleteme.com/Cribsiders, code Cribsiders. All right, Sydney, let's bring us on to our next patient who might be a little bit older.
All right, yeah. So later in that day, you see Sophia, a 22-month-old girl, for a routine well child visit. She is being raised in a bilingual English-Vietnamese household. Her parents report that Sophia consistently uses only about 10 words total across both languages, including mama, dada, no, and a few food-related words. They're concerned because their older child was speaking in short phrases by this age. During the visit, Sophia engages with you appropriately, including making good eye contact and pointing to request items. Her parents say that she correctly follows one-step instructions in both languages and can point to familiar objects and body parts when named. There are no repetitive behaviors, she has not lost any previously acquired skills, and her play is imaginative and age-appropriate. So I think we briefly touched on this before, but I would love if you can just reiterate and maybe expand upon the process of speech development in toddlerhood.
Yeah, so we'll kind of start where we left off. So 12 to 18 months, they start to identify objects when named, and they can understand simple questions like, where is dad? They say about 5 to 20 words by 15 months and 20 to 50 words by 18 months. So this little 22-month is definitely delayed in her expressive language. They start to shake their head no and point to show interest in something, not just because they want it, but to show interest in something. That's key. When they're 18 to 24 months, they start to point to body parts when asked, as this little girl is doing, and following two-step commands. They say about 50 plus words, so more than 50 words, and combine 2 words together. And they're about 50% intelligible by a stranger at this age. They also begin to engage in pretend play, some things that she's doing, right? Following multiple step directions or she's following one-step directions and engaging in pretend play. By 24 to 36 months of age, they follow 2 to 3 step directions, and they understand who and what questions, and they say about 300 to 1,000 words by 3 years of age, and they have 3 to 4 word sentences, and they're 75% intelligible, and they can take turns and talk about their experiences.
So we've learned a bunch from the first case. So now we know, hey, we've noticed an issue for a second here. We are going to order hearing testing. Then let's say this hearing testing returns normal again. And then we refer to, since we're still less than 3 years of older, early intervention and or SLP in your region. And so what happens during those visits or EI or SLP evaluation for a toddler compared to an infant?
Yeah, so most speech and language pathologists or early intervention, they're going to gather a history like we would. They're going to use standardized testing. So it depends. Every state's a little bit different in terms of early intervention, what tests they use. A common one is the Battelle Developmental Inventory. If you're assessing an evaluation, an IFSP, and that's what early interventionists will create, an IFSP. If you're reviewing that and you see that they've used a measure that's a parental report, you want to be kind of concerned about that potentially because it might be a little skewed, right? Versus a standardized test where they're actually testing the child to assess their receptive and expressive language. So usually they assess for those things. So receptive language, expressive language, their articulation they can also assess for, as well as pragmatic language. And so then once they identify if there's a delay or deficit, then they'll institute therapy and also assign homework for parents to work on at home with the child.
And can you tell us even just a little bit of what the therapy might look like with these kids? Is it mostly playing games? Is it mostly pointing to pictures in books? What does speech pathology, what does speech therapy look like for a toddler?
Yeah, it's a great question. And it depends, right? So if the child has a speech and language, if they have a speech disorder, then they're going to work on building that child's capacity to speak, right? So that's like working on how to form specific speech sounds correctly. If it's a phonological disorder, meaning that they have a hard time with sounds, the sounds that letters make, then they'll work on identifying those sounds the letters make and how to combine those sounds together, which is the building block for sounding out words. If it's a fluency disorder, so that means that they have a hard time, they get interrupted in their ability to, it's like stuttering or stammering. They have a hard time with the way the speech flows, then they'll work on improving that. If they have a voice disorder, like a pitch, volume, or quality of the voice, they'll work on that. And if it's a motor speech disorder, things like dysarthria or apraxia, they'll work on ways to build the muscles to help create the sounds using their mouth muscles. If it's a language disorder, so it's a receptive language disorder, they're going to work on improving their ability to understand spoken or written language. This happens for young children and for older children. If it's if it's an expressive language disorder, they're going to help them work on how to use words appropriately, how to put thoughts together into words as well, and create statements or sentences or descriptions of stories. And if it's a pragmatic language disorder, which is the social use of language, then they'll work on things like taking turns in conversations, helping them understand things like sarcasm, and how to use their verbals and nonverbal skills together effectively. That's a big, long answer for your question, but hopefully that helps.
I actually wanted to have a follow-up question about this because you kind of brought it up earlier, and there's no good part of our case to bring this up, so I'm going to bring it up here. The pragmatic speech delay. You talked about the intertwining between autism and speech and language, how those are so kind of mixed together. Is there anything that we should know about that? We've had a kind of a separate episode on autism that people can check out, and we walk through a lot of the diagnostic criteria that way, and at least the evaluations. But is there anything that we should know when it comes to the speech delay that might be associated with that?
The short answer is yes. So when we're concerned about autism spectrum disorder, as you guys talked about before, there's two buckets of symptoms, right? There's the difficulty with social communication, and there's the repetitive restricted interest patterns of behaviors, etc. So if a child doesn't have the second bucket of symptoms, they don't have the sensory sensitivities or repetitive behaviors, the intense perceptive interests, the routines and rituals, they don't have any of that, but they struggle with social communication, then we have to think, okay, this must be, or could very well be, a pragmatic language disorder in isolation. So that's where we identify, okay, is this autism, which means I have that pragmatic language disorder and I have the other things, or it's just a pragmatic language disorder if I just have this and I don't have the other.
That's super helpful. That's exactly what I was hoping to understand. I know I left that as a very broad, open question, but now I can definitely see the differentiation and that this is that component. And so if it's an isolated component, you say, okay, is this the primary disease process, or is this actually a component of a different, larger disease bucket, which we would include various different forms of the autism spectrum disorder. And I can see how they could use both when it comes to speech and language pathology to help them with through all of those pieces. All right, Sydney, sorry, I took us off track. Feel free to jump on to your next question.
No, it's totally fine and very interesting and helpful. I am though going to zoom back to a different part of the case, which is the fact that this child is growing up in a multilingual household. And I would love to get your thoughts on how does that affect language development? What are the differences that we see in those contexts?
It's a great question. I think it's really important to remember that learning two or more languages does not cause language delay. I think that can be a myth or misconception in our communities. The trajectory for kids who are in multilingual households might look a little different, but the outcome is comparable. So when we're assessing like the number of words that the children know in multilingual households, we want to make sure that we're asking about all the words they know in both languages, right, to get to our max number. Code switching for kids in multilingual households is also pretty common, right? They might mix various languages in a single sentence. And it's important for us to recognize, too, it's not confusion or a deficit. It's really just finding the most efficient word that's available to them in the moment. And so milestone timing also might be a little bit different for kids in multilingual household. In some instances, the first word might appear a little bit later. So it might appear instead of 12 months, like 12 to 15 months of age. And then sometimes mastering complex, so different languages have different grammatical rules. And it might take children a little bit longer time to sort of sort that out between the two different languages or multiple languages that are going on as well, but they catch up really quickly. So one of the things we do give as advice to families where there's children in bilingual homes is not to combine the languages. So don't use Spanglish. If you're going to speak to them in a language, like fully speak to them in that language, and then, later switch to the other language, but not combine them.
I think our next question was going to ask a little bit about some social determinants of health. I do want to say that we are now myth busting that multilingual environments do not necessarily mean that you have a language delay. As you were saying, we got to add up both of those words and say, okay, your word in each language added together and you get your total number of words. But having said that, are there other environments that you know of or other social disparities that are connected with language delays?
Yeah, there's classically something called it used to be called the word gap, and now it's been renamed the experience gap or the opportunity gap. And that has to do with what we talked about before, like exposure to words. So our language development, as we discussed before, is really deeply tied to our environment. So the more words you hear, the more words you say, and our vocabulary size is the number of words that we know is strongly correlated with our IQ scores and our later academic success. So the more words we can expose our children to at a younger age, the greater the benefit for them now and in the future. And it's not just the quantity, but also the quality. Like we talked about before, that back and forth interaction of you say something, I say something. And other things that can impact children, particularly around social determinants or societal disparities, include things like access to resources and access to care. So, and I know we mentioned this before, but I can't mention it enough, like access to books. We know that reading aloud is the single strongest predictor of early literacy, especially when we're talking about K-Ready and the kindergarten or the preschool to prison pipeline. So the more that we can expose kids to language, the improve the literacy that they have, the likelihood they have increased likelihood to graduate from high school and to go on to do amazing, tremendously awesome things. Access to evaluations and services. So there's as you guys know, as pediatricians and those listening, there's long wait lists, there's difficulty with transportation, ability or inability to take off time from work, as well as barriers with insurance. We also know that families that experience food insecurity, housing instability, or unsafe neighborhoods, they have less mental health bandwidth for rich interactive play that fuels language growth. And it's important to remember that this is a systems issue and not a parenting failure as well. And then when kids are exposed to lots of toxic stress, it leads to that elevated cortisol that we're all aware of, and that can impact the developing brain, that can impact one's ability to their memory, their attention, their language processing. And then I can't harp on this enough, but screen time, right? So screen time, even things like, I'm not going to name names, but certain programs that are out there that tout that's going to help your child build your pre-academic skills are not necessarily that beneficial to our children in the end.
Thank you for that. It sounds like there are a lot of factors that go into it. And it kind of comes back to the answer to a question in the previous case about really just the exposure to language and the access to the time, the energy of that language is huge, and the books and the literacy. So thank you.
I gave a talk recently on seizure versus syncope, one of those distinctions that trips people up at 2 a.m. I wanted a diagnostic flowchart clean enough to actually use at the bedside, so I sat there going back and forth with Claude on it. What came out was genuinely beautiful. Clean typography, color-coded branches, the kind of thing you'd actually want to put on a slide. I've never gotten a chart to look that good on my own. And so Claude is the AI for problem solvers. It's the collaborator that understands your entire workflow and thinks with you, not for you. Whether you're debugging code at midnight, building a financial model, or strategizing your next business move, Claude extends your thinking to tackle the problems that matter. And when you're reading up on something before a ship, deep research goes way past a basic search. Dozens of sources, real citations, hours of readings in just minutes. And so, Cribsiders listeners, for problems worth solving, get started with Claude at claude.ai/Cribsiders. That's claude.ai/Cribsiders, and check out Claude Pro, which includes access to all of the features mentioned in today's episode. claude.ai/Cribsiders.
One other thing that I've heard about with language development in this phase is this idea of a period of language explosion, where all of a sudden a kid goes from saying a few words to like talking a whole lot, and it seems to happen like overnight. So as long as we're myth busting, is that a real thing? If so, is there a expected timeline for it? Are there factors that would suggest it's coming? Or am I reading too many mom blogs?
Yes, it is a thing, but it's a little bit more nuanced than a word explosion really suggests. So as we looked at and we talked about some of those developmental milestones, so generally between 18 to 24 months of age, a child jumps from about 50 words to about 50 plus new words per week. So, and combining two words together, such that by 3 years of age, they have hundreds up to 1,000 words. So definitely over that course of time, it can be an explosion. The difference is, or the nuance is, that some kids, like you said, seem to like have this explosion overnight, and some just have a general gradual progression over time over those course of those months. And for some, it starts at 18 months, and others, it starts at 24 months. So it really can be that range between 50 to 30 months of age.
All right, we're going to kind of wrap up this toddler case before we move on to the grade schooler. But anything else that you recommend families should support language development in the home at this age? Anything different than you mentioned as an infant, which was read, play, respond to words, avoid screen time, and try to talk as much as possible with both as many words that have quantity and quality, as you were just mentioning. Anything else that we should know? Anything different about the toddler years?
Yeah, I think a big thing is like really responding. Let the child take the lead and respond to them, right? So, we want to talk with them. We want to talk about what they're interested in too. If there's ways we can expand their utterances. So if they say ball, then we want to add to it and say things like, yeah, that's a big red ball, right? Adding to it so they can get some of those more complex language integrated into their vocabulary. And then responding to gestures. So, gestures are really, those nonverbals are really important parts of our language and also part of our social interaction. So really paying attention to them and acknowledging them and reinforcing them and engaging in that back and forth part with gestures, not just language, but gestures as well, is really important.
I actually had one follow-up to that. So toddlers often use words that are unintelligible. We mentioned that, okay, by 3, if they have a, less than 75%, we should be concerned. But at this time, probably not. Do we need to respond back with, no, this is how the word's supposed to be said, for example? Do we need, is it more important to say, add on those things like a big red ball, or is it more important to say, no, it's ball, not wall? You know what I mean?
Yeah, we always talk about in behavior management, like, gentle guidance, right? So it's much more beneficial for kids when we gently say, oh, yes, that is a ball. I like that ball. Right. So I'm overemphasizing, like they've a hard time with L's, for example, and I'm overemphasizing the L, but I'm doing it in a gentle, kind manner. The children are going to pick up on that. And they're, especially those really social kids, they're going to imitate it and try to say it similar to what we said it. But if we, do it in a harsh way, then it's really going to negatively impact our children, right? It's going to impact their self-esteem, their self-worth. It's going to make them less likely to want to say the words. They don't want to get the criticism potentially around it. So the more we can do it in a gentle, kind, loving way, the more likely we're going to help facilitate their development or developmental progress.
Perfect. All right, Sydney, let's get our older kid now.
All right. So last case. Finally, you see Marcus, a 7-year-old boy who is brought to Cash Select Children's by his mother due to concerns from his 2nd grade teacher about academic performance. His teacher reports that Marcus struggles with reading aloud in class, frequently mispronounces words, and has difficulty with spelling tests. His mother notes that Marcus has always been hard to understand when speaking, particularly with certain sounds, and that family members sometimes ask him to repeat himself. She mentions that his kindergarten teacher had similar concerns, but suggested he would grow out of it. On exam, he's cooperative and engages appropriately. During conversation, he consistently misarticulates several sounds, such as substituting W for R, like saying wabbit for rabbit, and the th sound for S, so saying thun for sun. His speech is mostly intelligible, but noticeably immature for his age. When you ask him to read a little bit, he demonstrates difficulty decoding words and makes frequent errors with words containing the sounds that he misarticulates. He does answer comprehension questions appropriately. So obviously, this is a pretty thorough evaluation for a primary care clinic. I'm impressed with anyone that has the time to watch a child read and understand their decoding skills. But let's say that we have the chance to do this. I would love if you could talk a little bit just about generally our impressions of school-age children and what does a language delay or disorder look like, and what does a speech delay or disorder look like?
Yeah, it's such a great differentiation because based on this case, it looks like there's a little bit of both going on. So language disorders have to do with difficulty understanding and or using words in context. So it's a difficulty of meaning of communication and not the sounds, while speech disorders are difficulties with physical production of sounds. So the child may be hard to understand or produce sounds incorrectly. So when we're talking about a language disorder, we're looking at, again, the receptive language. So children this age, so school-age children, have to do with, do they have a hard time understanding spoken or written language? Do they have a hard time following directions? Do they not understand questions? Do they have a hard time with reading comprehension? In terms of expressive language, what is their vocabulary? How do they speak? Do they speak in short, simple sentence, or are they speaking in more of a complex sentence that we expect in an older age child? And how do they do telling stories that have a beginning, middle, or end? And then pragmatic language, like we talked about too, like taking turns in conversations, understanding sarcasm, how do they use their nonverbal communication. And then in terms of speech disorders, there's articulation like we talked about, like that substitutions, as you mentioned, that's going on for this case, for this child. And then phonological disorders, so dropping the ends of sounds like calf or cat, or top for stop. So simplifying consonant clusters like top for stop, so they're taking out the S and they're just saying the T. Fluency disorders, so stuttering or stammering. And then voice disorders, so chronic hoarseness, nasal quality, voice that's too loud or too soft. And then motor speech disorders like the dysarthria, which means weak muscles, or apraxia that has to do with brain. It's impacting our brain. It makes it hard for us to effectively control our oral musculature to effectively make sounds.
In this case, our second grade teacher said, hey, I was concerned about academic performance. We'll just keep it kind of broad. Instead of saying, okay, I'm concerned specifically about this being a language issue, I'm concerned specifically about this being a speech issue. You gave us the differential diagnosis essentially right there. But sometimes the teachers are like, look, I'm not a doctor, but you should go talk to your doctor about it. And so then when you come to see us, is there any way that you would recommend we try to sort this out in the primary care office, or you recommend that we send for either have the school do, kind of these types of testings, or send to a speech and language pathologist?
Yeah, it's such a great question. So you can do both, right? It just depends where you are, where you live, how easily accessible services are in the school. Because, right, the IDEA Act from the 70s says that if any child, you're concerned about them having a disability that adversely affects their educational performance, they have a right to a full and individual evaluation, no matter their age. And for those 3 and older, up to 21, they can get that evaluation through school. And schools vary across the country, right, in terms of how comprehensive their evaluations are as well. So you might start with the school, especially if there's long wait lists to get into speech and language pathologists where you are, or, how accessible it is to get, you might live far away for a speech and language pathologist. It's always good to make sure they're also doing it with the school, because they can get services, right? They can get an IEP in place, which will help them provide them specialized instruction in school. I will say that schools will only address speech and language issues as they pertain to one's academic performance. So if a child has an articulation disorder, not all schools will deem that impacting the child's academic functioning. So they may or may not work on them with the articulation disorder. So that might be something that you have to refer them to a private speech and language pathologist. Many times in schools, when kids do qualify for an IEP, they might get speech and language therapy as part of a group and not individually, which then it might dilute some of the individual therapy the child's receiving. So for those kids, I'll also refer them to an individual speech and language pathologist to get more intensive therapy individually. And especially so the parents can meet with a speech and language pathologist and get some things they can practice at home. I like to say that, bring up that old adage that if you give somebody a fish, they eat for a day, but if you teach them to fish, they eat for a lifetime. And the same is true for therapy. So if we can teach parents how to implement some of these therapies in the home, then that child's going to make tremendous gains. If you go to therapy 2 hours a week, that's great and that's amazing, but that's not going to cut it. We need to have the practice at home as well.
Yeah. So on that note, I would love to know more about what parents can do to get some of those skills to assist their children at any age, whether it is maybe this school age where the kid might be able to be a more involved participant, or for younger kids. I think it'd be great if we can start to direct parents to tools they can use on their own.
Yeah. So if a child is experiencing disfluency, one of the common things is sometimes we want to fill in the gaps for them. So here's a nice strategy, which is basically to wait and to watch and to listen and not jump in right away and fill in the gaps for them. Instead, offer them some positive support, like, it's okay, take your time. I've got nothing but time, Providing visual supports can be really helpful. So pairing words with pictures. So some children do really well visually spatially, but they have a hard time with verbal. When we break out, for example, IQ testing, we look at their verbal skills and we look at their visual spatial skills. So some kids might struggle with their verbal skills, but they do really well visually spatially. So if I give them an instruction and I pair that with the visual, whether that's pictures or demonstration, that is going to improve their ability to follow through with the task that I've asked them to do. So, and visual schedules can be also very helpful for them as well. There's something called recast and expand. So similar to what we talked about before, if a child says, dog run, then you would say, yes, the big dog is running really fast. So ways to just add on to that to help them build that expressive language and to speak in complete sentences and be able to relay a story. Word webs also help. So you can pick a word and you can talk about it. So pick a word like park and say, where is the park? Or what do we do at the park? Or what's at the park? So asking them some of the what, where, etc. questions that help them to think about it and to answer. I know that they might not be able to answer it, and that's okay. We're just stimulating their brain to think about it, and then we're providing them that gentle response, and then that's more likely to stick in their brain, which is something we talk about with residents too, right? We ask them a lot of questions to help those answers stick in their brain for later. You can play with synonyms and antonyms. So you can say, oh my gosh, that was huge. What's another word for huge? Or is cold the opposite of hot or tired? So you're giving them options. You're not like having them come with it spontaneously, but you're giving them some things for them to think about, options to choose from. The other thing you can work on is retelling a story, like, read a story together and then ask them to recap what happened in the story. Or even if they're watching something, a show like Bluey on TV or a movie, ask them to tell you, what did you like the most about it? Or what do you remember about the story? Or tell me what happened. You can role play scenarios. I love role play. Role play is such a great way for kids to build their language and their social skills. So they can role play different scenarios, which also help them build their language. And then it's also important to validate their frustration. They recognize when they're feeling frustrated and to respond and not to react, especially if we're getting frustrated as well. There's some things we don't want to do. We don't want to force correction. We don't want to finish their sentence. We don't want to compare them to other people or other siblings. And we don't want to overwhelm them, right? It pushes them too much and leads them to shut down.
Those are fantastic tips. And I think we have a lot of skills that we can all use to make these things, to improve these things, both at home and at school, and make recommendations. And so I think we have covered so much. My question for you, before we kind of wrap up, is there anything that we're missing about speech and language delay in an older child here? Anything that we forgot to ask you? Anything that we should really know? And then we can go to some take-home points.
Yeah, I think you covered all of it. And you guys did a phenomenal job.
Awesome. Well, actually, I do have a question. Now, this is just the fact that we have a developmental behavioral pediatrician on, and one of your greatest skill sets is actually really diagnosing where some of these things come from. I remember when I was doing my rotation with the developmental behavioral pediatrics, you guys performed a lot of those tests. A lot of those evaluation tests. You guys were excellent at really deciphering and walking through a lot of those tools. If we don't have access to a developmental behavioral pediatrician, we're trying to figure out how we can best do these evaluations. Do you have any specific recommendations on maybe who we would ask to do those? Do you recommend a neuropsychologist to try to, if you have a kid, for example, who has academic issues, a question about academic performance, and you're like, all right, I'm trying to figure out if this is speech, or is this really language, or is this actually something else? Is this like ADHD? Is this going to be something different? And I'm trying to sort through those things, and I don't have access to a developmental behavioral pediatrician. Is there someone you'd recommend doing tools and testings for, asking the school, or anything we should do as a primary care pediatrician?
Yes, I would say always starting with the school, right? So even if somebody's in homeschool or private school, they can go to the local public school and request testing. And so when they do that, it's important to make sure they do it in writing, right? So when you do it in writing, it documents that you have requested it, and there's a time frame attached to it as well. So if you're not hearing back from them, you can implement legal support. So always going through the school, and the schools are supposed to provide a comprehensive evaluation. So if the concern is language, they can't just do an IQ test. They're supposed to do an IQ test, a speech and language evaluation, a hearing and vision, and academic achievement testing. Now, it depends where you live, right? So despite what it says, you may or may not be getting those comprehensive evaluations. And in that case, then I would refer to a psychologist who's going to do intense psychoeducational testing. And there's a difference too. I think it's important for your listeners to know. Oftentimes we think we need to do neuropsych testing. That gets thrown around a lot. So you don't need to do neuropsych testing. Like neuropsych testing is pretty intense, like literally all day long testing. So kids with brain injuries or tumors, like they might have neuropsych testing. But if you have a child that you're concerned about their IQ or learning disabilities or speech and language, etc., then psychoeducational testing is really all that you need. And that might be paired with a speech and language pathologist evaluation and or occupational therapy, which will look at fine motor stuff, adaptive living, ADLs, stuff going on for them, as well as sensory processing stuff, and potentially physical therapy as well if they have gross motor delays.
Yeah, and that's actually a very good differentiation for me to know as well, right? Because we throw around neuropsych all the time but really psychoeducation is what you're saying. So thank you. That was kind of a side note. That was more for my education than hopefully some of the listeners found this useful. If not, we can absolutely remove it. And so let's jump to some take-home points. So we did 3 great cases. Talked a lot about some language delay. And what are your main take-home points you think for our listeners? If you had maybe 1, 2, or 3 points.
1, if you suspect that a child has a speech or language delay or disorder, get them evaluated. You can never go wrong. If you
Done. Yeah.
Right? It's better off to get them evaluated and have them say they're fine than them not get evaluated and go untreated. And then, when I always ask the patient, always ask the family when they come in, if they're getting therapy, what is your child doing in therapy? And what are you learning through the therapy that you're helping the child work on at home? I think it helps to kind of shift that onus that it is our responsibility as well, right? We are a broad-based team. I mean, we as parents, right? We're a broad-based team, including the primary pediatrician or family practitioner or whatever kind of provider, a nurse practitioner, as well as the parents and the therapists. And we're all working together, but we all have our part to play. And it's important for us to remember that, parents play a huge role. And the more that they're learning these skills and strategies and doing it, the more impact we're going to have for our children to help them reach their greatest potential. I have a little diagram that shows, okay, if you get no therapies, this is where you're going to go. If you just get speech and language therapy in an office, this is where your child's going to go. If you get speech and language therapy and you're doing stuff at home, this is where you're going to go.
Awesome. And then is there anything else you'd like to plug? Any websites, any graphics, any societies, anything that we should know about your Twitter or X accounts, anything that we should know or can plug for you?
No, use your local experts.
Perfect. And go and for those interested in developmental behavioral pediatrics, go DBP.
Oh my gosh, yes, please. Many people actually come to DBP after doing pediatrics for a while in general practice.
Go. Awesome. Well, thank you so much for coming on the show. We really, really appreciate it.
Thank you.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Sydney Engel, and our wonderful social media team, which is mostly Denise Cruz and X Blue Sky on Instagram. I've been Sam Mazer.
I've been Sydney Engel. Thank you, and good night.